Clinical chemistry, diagnosis of carbohydrate disorders. So diagnosing diabetes mellitus is first off based on some symptoms. So clinical symptoms related to hyperglycemia include polyuria, increased urine output, polydipsia, increased thirst, polyphagia, increased appetite. Other symptoms include weight loss, increase in bacterial or yeast infections, fatigue, blurred vision, frequent vaginal infections or cessation of menstruation, and impotence. The diagnostic criteria, you would have the symptoms of diabetes plus a glucose level of greater than 200 mg per deciliter or fasting plasma glucose of greater than 126 mg per deciliter or 2 hours post-load glucose of greater than 200 mg per deciliter during oral glucose tolerance test. Glucose load equivalent to 75 grams anhydrous glucose dissolved in water, and it's not recommended for routine clinical use. This is a table that you should take some time to review. It gives you some diagnostic criteria and talks about the information that I summarized previously and that I'll talk about in a little bit more detail as we go through these slides. So laboratory tests include the measurement of blood glucose. A diagnosis of diabetes is based on the presence of elevated blood glucose and clinical symptoms. Routine screening of those people that are greater than 45 years old is now recommended. Tests to monitor diabetic patients include glycated hemoglobin, HbA1c, and the detection of microalbuminuria for the monitoring of nephropathy. The detection of acute crisis situations include hypoglycemia, ketoacidosis, lactic acidosis, hyperglycemic, hyperosmolar, non-ketotic ketotic coma. So fasting plasma glucose, levels of greater than 126 mg per deciliter is highly suggestive for diabetes mellitus. 110 to 126 is borderline, directly proportional to the severity of the disease. So levels greater than 126 coincide with an increased incidence in retinopathy, nephropathy, and fatal coronary heart disease. Glucosuria may be observed with levels of greater than 180 mg per deciliter. So glucosuria is talking about glucose in the urine. Under normal circumstances, there would be no glucose in the urine. So when we start to see glucose pouring over into the urine, we know that there's an issue with elevated blood glucose levels. Ketoacidosis can occur with levels greater than 140 mg per deciliter. Wide swings in plasma glucose levels even in controlled diabetic patients. So this is just a summary table that you can review showing the different levels and whether it's considered hyperglycemia, hypoglycemia, or normal. So normal blood glucose would be 70 to 110 mg per deciliter for fasting plasma glucose concentration. It's important to the differentiation of hyper from hypoglycemia in diabetic patients. Sample considerations, blood versus plasma. Fasting whole blood glucose is 12 to 15% lower than plasma glucose. Why do you think that is? So if we use whole blood, there's cells in there, and cells are going to be consuming the glucose as they sit in the tube. So they're going to have lower glucose levels. Capillary versus venous blood. During fasting, capillary blood glucose is 2 to 5 mg per deciliter higher than venous blood. With glucose load, capillary blood glucose is 20 to 70 mg higher than concurrently drawn venous samples. Why is capillary blood higher in glucose levels? It's due to the tissue proximity. Sampling considerations: avoid hemolysis, avoid glycolysis, decreases serum glucose 5 to 7% per hour in normal uncentrifuged blood. Higher with leukocytosis or bacterial contamination because the bacteria and the white blood cells are going to be consuming the glucose. Glucose concentration is stable in non-hemolyzed sterile separated serum. 8 hours at 25 degrees Celsius or 72 hours at 4 degrees Celsius. Separated plasma contains leukocytes. It's inhibited by the addition of sodium iodoacetate or sodium fluoride to the specimen, and this is stable at 3 days at room temperature. Sodium fluoride is a weak anticoagulant. Sodium fluoride or potassium oxalate. The addition interferes with other assays. The fluoride inhibits urease and other enzymes. Potassium oxalate causes the loss of cell water, diluting the plasma. It does not affect the rate of glycolysis in the first hour, typically not necessary if samples are analyzed within 60 minutes. Cerebrospinal fluid may be contaminated with cells or bacteria. It should be analyzed immediately, centrifuged and stored at 4 degrees Celsius or -20. Urine is not a good marker for diabetes. Normal renal threshold 180 mg per deciliter, increased in diabetics to 300 mg per deciliter. Large dilution typically required, preserved with addition of 5 mL glacial acetic acid to inhibit bacteria. Other proposed preservatives may not be satisfactory, stored at 4 degrees Celsius during collection. Methods for evaluating glucose levels. The Benedict's method is one of the most common. It detects total reducing sugars. It's based on the reduction of copper with glucose to produce a colored precipitate. It's used as a urine screening test for newborns and the detection of inborn errors of metabolism. There's the hexokinase method, which is a coupled reaction that causes, again, a color change, and it's measured at an absorbance of 340 nanometers. Glucose oxidase method, or the Trinder method, causes a color change, and that color change can be quantified. It's suitable for urine, blood, serum, CSF, and glucose oxidase is highly specific for beta-D glucose. Interferences. Coupled peroxidase method is a nonspecific and it accounts for interferences in the assay. Uric acid, ascorbic acid, bilirubin, hemoglobin, tetracycline, glutathione inhibit the reaction. Catalase contamination in the reagent acts to decompose peroxide, inhibiting the reaction. Glucose dehydrogenase method is listed here. Mutarotace is added to convert alpha glucose to beta glucose to decrease the reaction time. It's highly specific for glucose, not susceptible to interferences from anticoagulants or other interfering substances that are commonly found in serum. It's also suitable for cerebrospinal fluid. It agrees well with the hexokinase method. Despite these advantages, it's not commonly used in the United States. Functional glucose determinations. Postprandial plasma glucose is the measurement of the clearance of a glucose load, typically following a consumption of 75 grams of glucose in a drink. Sample is drawn 2 hours after the consumption of the drink or meal. Glucose levels of greater than 200 mg per deciliter at 2 hours is indicative of diabetes. So the patient would consume the 75 grams of glucose, wait 2 hours, and then glucose levels are measured. If it's greater than 200 at that 2-hour time limit, then that is indicative of diabetes. 2 consecutive tests are recommended for diagnosis. It's widely used but highly inaccurate. Variables include age, weight, previous diet, activity, illnesses, medications, the time of day, the actual size of the glucose dose. When the meal is used as loading dose, results depend on digestion and absorption of the disaccharides and polysaccharides. So we have the oral glucose tolerance test. It evaluates glucose clearance under defined and controlled conditions. It's standardized by the Committee on Statistics of the American Diabetes Association. This is not recommended for standard use. It may be necessary in the following conditions: the diagnosis of GDM, gestational diabetes mellitus, diagnosis of impaired glucose tolerance, evaluation of unexplained nephropathy, neuropathy, or retinopathy with random glucose less than 140 mg per deciliter, population studies for epidemiologic data, or borderline fasting glucose levels. Standard conditions: a minimum carbohydrate uptake or intake of 150 mg per day for 3 days prior. Intake less than this lowers the intolerance. 8 to 16 hours fast prior to testing. The patient must be ambulatory. Inactivity decreases intolerance. Exercise and emotional stress should also be avoided. Factors that affect the oral glucose tolerance test: illness reduces the tolerance. Hormonal abnormalities such as thyroxine, growth hormone, cortisol, catecholamines, certain types of drugs. The time of day: you want to conduct the test between 7 a.m. and noon. Evaluation should be adjusted for age. And glucose load should contain glucose only, no dye or polysaccharides. The load size should be 40 grams of glucose per meter squared of body area. Typically, that equates to 75 grams of total glucose. Interpretation: greater than 200 mg per deciliter at 2 hours is suggestive of diabetes mellitus. The shape of the curve provides the information. Concurrent insulin determination is useful. It helps to differentiate type 1 versus type 2. There's no standard technique. RIA or radioimmunoassay and ELISA are used. So laboratory testing, in addition to the measurement of blood glucose, which is now routinely recommended for anyone greater than 45 years of age, there are tests to monitor the diabetic patient. So glycated hemoglobin, HbA1c, detection of microalbuminuria, monitoring of nephropathy, and these that are listed below. So this is a repeat slide from earlier. And we're going to talk about glycated hemoglobin now. So glycation, the non-enzymatic addition of a sugar residue to the amino group of a protein. Glycated hemoglobin comes in 3 different fractions: HbA1a, HbA1b, and HbA1c. It's also referred to as fast hemoglobins. Glycohemoglobins, glycosylated hemoglobin, glucosylated hemoglobin. HbA1c is the predominant fraction, so 80% of HbA1 is HbA1c. It's formed by the irreversible condensation of glucose with N-terminal valine residue of each beta chain of hemoglobin. So step 1, glucose reversibly binds to the accessible amino groups and forms aldamine, which is pre-HbA1c. Step 2, aldamine undergoes irreversible rearrangement to form codamine, HbA1c. Step 3, you have the formation of the glucose ring structure. The significance of HbA1c. It represents the integrated glucose values for the weeks preceding 6 to 8 weeks. So you can get one measurement that kind of gives you an idea of what's been going on in the body for the previous 6 to 8 weeks. It's free of the day-to-day variation, and it's not affected by exercise or recent food ingestion. High levels are indicative of poor diabetic control. It's correlated with future complications, especially retinopathy. And then here's a chart that you can take a look at to read some more additional information. So the interpretation of hemoglobin A1c, 7% means there's poor control of diabetes, 6% means there's good control of diabetes, and 4% is the reference range. Misleading levels of HbA1c. It's falsely low in hemolytic anemia. There's an increase in new red blood cells and recent significant blood loss. It's falsely high in iron deficiency anemia and the other items that are listed below here. Methods for the determination of HbA1c. Separation based on charge differences, so ion exchange chromatography, HPLC, electrophoresis, isoelectric focusing. Structural differences, so affinity chromatography or immunoassay. And chemical analyses, so photometry, spectrophotometry, and the results are as a percentage of total hemoglobin. So going back to this, again, 7% of the total hemoglobin is A1C, then that would indicate poor control of diabetes. So this shows the three fractions, so A1C, A1B, and A1A, and you can see this is just one method of evaluating levels. Ion exchange chromatography, the column is packed with negatively charged resin. Red blood cells are lysed and loaded into the column. Hemoglobin is positively charged and interacts with the column. It's eluted with buffers with ionic strengths adjusted so that glycated hemoglobin is eluted first. So HbA1a, B, and C collectively measure HbA1, and that's measured spectrophotometrically. The remaining hemoglobin is diluted with a second buffer, and then that is determined spectrophotometrically as well. And then you get your percent hemoglobin. Analytical concerns, pre-HbA1c will elute with stable ketoamine, causes falsely elevated results. Hemoglobin F, or fetal hemoglobin, co-elutes with HbA1. Attachment of non-carbohydrate moieties to hemoglobin can interfere. And other hemoglobin variants are retained on the column, so HbS and HbC. Decreases the relative concentration of HbA and falsely decreases HbA1.